its restrictive properties maintained during ankle movement or walking. Next.
Your
So
time is up.
Thank you.
Any question from audience side? I request all my dear seniors and juniors to try to participate in question and answer session after completion of the presentation. By that, the scientific session will be more interactive and more knowledgeable. Thank you very much. If anyone wants any question, we'll give the mic to them and they can ask the question. I think no one interested. Okay, hope from next presentation you people will ask question. Thank you.
Thank you so much for sharing your research and insights with us. The next presenter is Ms. Ritu Patwari. I welcome you to the dais.
Good morning, everyone. Today I am presenting my research on the topic next. Effects of open and closed kinetic chain exercises on pain, strength and function in knee osteoarthritis, a pilot study. Authors Ritu Patwari and Vibhuti Sarkar sir. Introduction. Osteoarthritis is derived from the term osteo means bone and itis means inflammation, which is mainly a highly disabling joint disease. Prevalence rate found to be 28.7% in India, which is mainly affecting the adults of 40 to 70 years of age with varying degree of pain, joint dysfunction and often associated with progressive joint instability. Knee is the most affected joint. Women are more likely to have OA than men. Cardinal features include fibrillation, aberration, subchondral cyst and sclerosis and osteophyte formation. They are of two types, primary and secondary. Primary osteoarthritis occurs in old age, mainly in the weight-bearing joint. It is commoner than secondary OA. Secondary OA is, there is an underlying cause, which is degenerative cause mainly. Second, next. Risk factor of OA knee as per WHO, body mass index, repetitive movement of joint infection, injuries, obesity, waist-hip ratio, altered quadricep angle, osteoporosis, Indian cultural habit, hormonal imbalance, and certain unmodifiable kneeling, squatting, and prolonged standing and high sitting. Conservative management includes hot compression, tense, exercises include stretching and strengthening, NSAIDs, and corticosteroid therapy. There is a lot of debate on OKC and CKC in knee osteoarthritis. OKC that are performed when the hand or foot is free to move, whereas in the CKC, hand or foot is fixed to the ground. Some authors in literature concluded that both of them helps to maintain long-term functional outcome of knee. The proper mechanism is unknown, but it is said that tonic activation of nociceptive reduce presynaptic inhibition and reduce pain. Aims and objective of my study aims to compare the effect of open and closed kinetic chain exercises on pain, strength and function in knee osteoarthritis. Objectives include to find the individual effect of OKC and CKC on pain, strength and function and compare their effects. Next. Materials and method. It was a pilot study performed in the Department of Physiotherapy, NILD, Kolkata, in the month of March 2023 to November 2023. In the population with knee osteoarthritis, 16 subjects were included in the study who were referred from assessment clinic of NILD to the Department of Physiotherapy having knee pain or diagnosed with knee OA. Next. Inclusion criteria includes 45 to 65 years of subjects with knee OA with grade 3 Calgren and Lauren classification with duration of more than 6 months, and pain intensity will be between 3 centimeter to 8 centimeter. Exclusion criteria includes musculoskeletal condition like ligament sprain, etc. Severe deformity of spine, lower extremity like genu recurvatum, etc. Rheumatoid disorder like ankylosing spondylitis and rheumatoid arthritis, etc. Inflammatory disorders like septic and psoriatic arthritis, etc. Diagnosed neurological condition like CP and stroke, etc. were excluded. Subjects who are on oral steroids within 1 month or intra-articular corticosteroid over knee joint within 3 months were excluded. Next. Total 40 subjects with knee pain or diagnosed with knee OA referred to a Department of Physiotherapy from assessment clinic of NILD were approached for the study. 16 subjects were included who were screened for knee OA, and excluded 26 subjects were excluded, unable to come for treatments were 16 subjects, and 10 subjects were not meeting the inclusion criteria. Then written informed consent was obtained from the subject. They are randomized into two groups through block randomization using computer generated random integer. Then demographic detail and baseline data was collected on the outcome measure, pain intensity by VAS, strength by handheld dynamometer, function by Womack index, and then randomized into two groups. Group A includes 7 subjects who were treated with open kinetic chain exercises and moist hot pack for 15 minutes for 5 days a week for 2 weeks and home exercise program. And group B included 9 subjects who were treated with CKC and moist hot pack for 5 days a week for 2 weeks and home exercise program. Then all the subjects were all the data were collected after 10 sessions of treatment, and then data analysis were done. Next, Group A includes moist hot pack, then isotonic quadriceps using Q-table, isotonic hamstring, multi-angle quads in the degrees of 15, 30 and 45, VMO strengthening, isometric hams, isometric quads and posterior capsule stretching. Group B includes, next, mini squats, mini lunges by using stairs. We ask the patient to just fix his affected limb on stair 1 and then do forward, backward and sideways stair climbing, McConnell's VMO strengthening and posterior capsule stretching. Next. Statistical analysis were done using SPSS version 25 software. Chi-square test was used to check the homogeneity of male and female ratio. Pair t-tests were done to analyze within group analysis, and then independent sample t-tests were used to compare between group for the outcome measures. The results were taken to be significant if p-value is less than 0.05. Next. Result, in the baseline data, all the data were homogeneous and the p-value is more than 0.05. Next. Then in within group data, there is significant difference in all the outcome measures, VAS, strength and function in both the groups. That is p-value is less than 0.05. Next. In the between group comparison, there is no significant difference between two groups that in all the outcome measures, VAS, strength and function. Next. Discussion part, the primary goal of the study was to test the hypothesis that compares the effect of OKC and CKC along with hot pack on pain, quadriceps strength and function in subjects with knee OA. Next. The observed finding can be elucidated by considering that both OKC and CKC group followed a very similar progression in strength training. This leads to the inference that the two exercises modes yielded comparable effect on quadriceps muscle strength across the 3 measures. There are a few studies conducted. That is, one study was conducted by Olbegi et al., who employing a similar training progression found no discernible difference between OKC and CKC in terms of pain and function. Next. Traditionally, OKC has been preferred choice over CKC in the treatment of knee OA due to the concern regarding the potential induction of joint cartilage wear and tear CKC. Such concern arise from the apprehension that this wear tear could potentially accelerate the progression of the disease. Enhancement in daily function are well complemented by exercise that mirror everyday activities, and it has been demonstrated that functional activities such as walking encompass more component of CKC than OKC. The decrease in pain and subsequent enhancement in function resulting from quadriceps strengthening exercise have been associated with an augmented stability of the knee joint facilitated by the improvement in the quadriceps muscle strength. Literature evidence indicate that exercise aimed at enhancing quadriceps strength may activate pain suppressing beta endorphin system, exerting a positive influence on sensory input to the CNS and gait control mechanism. Next. Thus, my study suggests that both OKC and CKC are equally effective in improving pain strength and function. Thank you.
Why did you prefer to check the strength with a hand dynamometer? Why not the conventional manual testing?
सर मतलब जब हम लोग वो डाटा पुट करेंगे तो उसको सर शो करने में प्रॉब्लम होता है अगर एमएमटी यूज़ करते हैं तो.
Okay, how did you use the hand dynamometer?
सर एक वुडन ब्लॉक है 35 डिग्रीज एंगल में, देन उसमें हम पेशेंट का जो लीम है उसको स्टेबलाइज करते हैं एंड देन विद द बाय यूजिंग हैंडहेल्ड डायनोमीटर वी आस्क द पेशेंट टू डू आइसोमेट्रिक कॉन्ट्रैक्शन and there is a dial which shows the deflection that how much he is exerting.
It shows you in newtons.
force. Yes, sir. Newton also and kg also.
In kg also.
Kg per meter
So
square.
how do you make it equivalent to the MMT? How many newtons is equal to grade 3 or 4? How do we assess that?
Sir, they
It's
are.
okay, hand dynamometer will show you in newtons or kgs. Okay, now how would I know how many kgs is grade 3 or how many newtons is equivalent to grade 3? Manual testing.
So we can compare patient pre and post, and then we can see the improvement.
Okay, how many bilateral OA cases were there in this included?
Bilaterals, sir, I'm not remembering that now.
Were there any or not?
Yes, sir, many.
There were many. Okay, so if you are not knowing how many newtons is equal to a grade 3, normally the procedure is you have to test the opposite side.
Yes, sir.
The normal leg. Suppose that shows 50 newtons and the other side shows 30 newtons, okay, I can understand it is weak. But when you are having a bilateral OA, how do you judge which is stronger, which is weaker?
So there is a lot of researches are there, like according to their age there is, strength is fixed, so we can compare it with that.
What I'm trying to say is, it is good, but you see it's difficult to interpret that.
Yes.
Okay, hand dynamometer is used and an isometric contraction is tested, undoubtedly. But then the practical problem is that we cannot judge it accordingly. Okay,
Yes, sir.
so that should be borne in mind. Otherwise, presentation was good. Thank you.
Thank you so much, sir. Thank you. I'm sure your presentation has sparked meaningful discussions even among the audiences. Our next presenter is, I call upon our next presenter, Ms. Ranu Mukherjee. I welcome you.
Good morning everyone, good morning my teachers. Today I will be presenting my research paper on a randomized clinical trial to compare the effect of EMG biofeedback therapy and modified constant induced movement therapy for freestand finger extensor muscle activation in hemiplegic hand. It is authored by me and Saurabh sir. Introduction. In stroke survivor, functional limitation in hand is a major complication because it limits the ADL activities due to the presence of abnormal synergistic pattern. There are numerous approaches. Among them, EMG biofeedback therapy and modified constant induced movement therapy have been found to be very effective in this condition. Where EMG biofeedback therapy helps to retrain the muscle by recording their electrical activity and converting them into the auditory and visual feedback, and helps the patient to control it and maximize their voluntary effort by showing them to the original, to the real environment. And on the other hand, modified constant induced movement therapy helps to promote the motor relearning process in the patient by constraining the unaffected hand and through the repetitive practice through the affected hand for the most awaking hours. But for the patient convenience and motivation, Page et al. Modify its normal version and by reducing the time for constraining and as well as the practicing time by the affected hand. Next. To the best of our knowledge, there are no studies which comparing these two methods. So the purpose of our study was the efficacy of comparing the efficacy of EMG biofeedback therapy and modified constant induced movement therapy on wrist and finger extensor activation to break the abnormal synergy. Material and method, it was a randomized clinical trial, a comparative study performed in Department of Physiotherapy, NILD, from March 2023 to November 2023. 26 patients were included in this study, referred from the assessment clinic NILD, and randomization were done through the Brock randomization method. Next. Inclusion criteria were the male and female subject aged between 45 to 65 years, first stroke diagnosed by the physician, 3 months to 3 years, 4 stroke cases with patient with normal cognition power, brainstorm hand recovery stage 4 and 5, and spasticity grade less than 2 on mass scale. Next. Exclusion criteria included the severe pain in the affected arm or shoulder subluxation grade more than 2, any kind of visual or auditory defect, aphasia or any sensory impairment in the upper extremity. Other than stroke, if there is any neurological disorder or any musculoskeletal condition like fracture, contracture deformity. Next. Maximum voluntary isometric contraction by the EMG machine for wrist and finger muscle were recorded as an outcome measure. Next. This study was approved by the Institutional Ethical Committee NILD and it was also registered in ctri.nic.in. Next. 60 subjects were approached for the study, referred from the assessment clinic to the department. 26 among them were included in the study. Written consent were taken from the patient and randomization were done into 2 groups through block randomization method by computer. The demographic and baseline data were collected for MVIC value of wrist extensor muscle using EMG. 13 patients in group A were treated with the EMG biofeedback therapy and standardized exercise program for 4 sessions per week for 4 weeks. And on the other hand, 13 patients in group B were treated with modified constraint-induced movement therapy for 4 sessions per week for 4 weeks. After intervention, post-intervention data were collected and analyzed. Next. 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 These are the tasks patients were performed during their EMG session. Next. Like picking up the marbles, stacking object, pegboard activities. Next. Similar tasks patient were performed during their CIMT session and the unaffected hand were restricted by an oven mitt for 3 hours and repetitive task practice were done by the patient. Next. For statistical analysis, SPSS version 25 were used and for within group analysis was performed using paired sample t-test. The baseline characteristics and post-treatment data between 2 groups were analyzed by the independent t-test. Next. Next. Table 1 is showing that baseline data of the 2 groups patient which suggests that there is a homogeneity at the baseline in both the groups patient. Table 2 is showing within group analysis which shows that there is a statistically significant difference in both the groups, that is p-value is less than 0.05. Next. This is the graphical representation of MBIC value. Next. This is the between group differences of group A and group B, which suggests that there is no statistically significant difference in between both the groups because p-value is more than 0.05. Next. Discussion. The result significantly changes the EMG signals which is denoted by the MVIC values within group A and group B after intervention. MVIC value suggests that the activation of wrist and finger muscle activation which is crucial to break the abnormal synergy in hand. Next. In EMG biofeedback group, the improving MVIC value suggested by the Steven Wools et al. And Sethena et al. That may come from the facilitating plastic changes in the CNS and unmasking existing pathways or new movement strategies transferring function to intact neural structure using alternative pathways, and it's augmented by the audio and visual feedback allow the participant to modify the motor unit activity through vein reorganization. Next. And in the group B, MVIC value improved by the CIMT as suggested by the Sai et al. In his systemic review that repeated use of the affected limb can induce the cortical reorganization and enhancing the motor function and helps the patient to overcome their learned non-use phenomenon. And it is also suggested that it improves increases the motor fiber recruitment and maximize the voluntary motor control, reinforcing the outcome observed in our study. Next. In between group analysis, there were no statistically significant difference. That implies that both groups are equally effective to initiate activation of weaker extensor group of muscle, which eventually helps to break the abnormal synergy in stroke survivor. Next. So we can conclude that both groups are equally effective in the extension muscle activation. Next. So we can clinically apply this as EMG biofeedback is a viable option for institutional based rehabilitation as well. On the other hand, CIMT is a better option for home based practice. Thank you. Any question?
Can I ask you something? In your study, how many left hemiplegics did you have?
Sir, left hemiplegic.
You showed 5. I think you showed 5 there. 5 left hemiplegics you had.
Okay. Yes, sir.
Yeah. Was there any difference in the recovery between the left and the right?
Sir, because right side is the dominating side, so right side is recovering more fast rather than left because generally we didn't use our left hand, so it is there is a phenomenon called hemi-neglect. So in left side affection there is also this situation
so
is.
In short, you mean to say that the dominant side will always recover faster?
Yes, sir.
Okay. And for the constraint, what was the duration of the constraint?
So constraining duration we have used for 3 hours. According to the Page et al. Study, they also have also suggested that for patient convenience and motivation, the most of the working hours we can shorten, and from by changing it, practicing time from 30 minutes to 3 hours session, and by restraining time from 3 hours to 6 hours. So we have taken the 3 hours duration. And we have provided the patient a patient diary to maintain this, how much time they are wearing that meat. And we have provided an oven meat to every patient for that.
Okay, thank you.
Thank you, sir.
Thank you so much. I'm sure your insights have added depth to our collective knowledge in this field. Next in least for the presentation is Mr. Sanlap Kundu. I welcome you.
Good morning. Good morning, everyone. Today I am going to present a randomized control trial in front of you, which is a pilot study. So the title of the study is the efficacy of EMG biofeedback therapy along with Bobath therapy on lower extremity motor functions in patients with hemiplegia. So the study was done by me and my guide, Shri Praveen Kumar sir. So the background and the purpose. So stroke gait is distinguished by asymmetric and compensatory gait patterns that can be associated with altered spatial temporal gait variables. The retracted pelvis of the hemiplegic side along with inadequate active hip extension or increased ankle plantar flexion with a backward pointing that results hyperextended knee. So to control this, to improve motor function, there are various techniques like neurofacilitatory methods, Bobath, Brainstorm, PNF, etc. And the Bobath therapy here aims to regain the normal movement of the hemiplegic side through neuroplasticity shaped by manipulating afferent inputs. The biofeedback therapy, on the other hand, helps in motor training by gaining control over the selective motor unit activation. So there are lots of studies which shows that biofeedback therapy single-handedly improve the motor function, and there are studies which also shows that EMG biofeedback therapy can or cannot improve the motor function. So here I am comparing in both of these therapy. So the aim of the study is to find out the efficacy of EMG biofeedback therapy along with Bobath therapy on lower extremity function in stroke patients. So the aim and objectives of the study, the aim is to find out the efficacy of the EMG biofeedback therapy along with Bobath therapy on lower extremity functions in patients with stroke. And the objectives are to find out the efficacy of EMG biofeedback therapy along with Bobath therapy on lower extremity functions, to find out the efficacy of Bobath therapy on lower extremity functions, and to compare the efficacy of EMG biofeedback therapy along with Bobath therapy on lower extremity functions. So the material and methods, the study design, it's a randomized clinical trial. The place of the study is here, NILD. The period of the studies were 8 months, April 2023 to November 2023. The study population, patients with stroke. A total 20 patients were included in the study, and patients were referred from the assessment clinic of NILD to the Department of Physiotherapy. The sampling design was block randomization method by using computer generated numbers. Now, the inclusion criteria and the exclusion criteria. For inclusion criteria, both male and female patients aged between 40 to 65 years, patients with first attack of stroke diagnosed by a physician, duration of stroke 3 months to 3 years, patient has no cognitive impairment, has an MMSE score of greater than equals to 24, grade of spasticity up to 2 in lower extremity on modified Ashworth scale, patient is in Barnstorm lower limb recovery stage 3 and 4, patient should have passive 10 degree or greater angle dorsiflexion, patient can sit independently on a plinth, and patient should be ambulatory either independently or with some assistive aid. For the exclusion criteria, patient with hemisensory loss of the involved lower extremity, problems with vision like homonymous anianopsia, etc., patients with hearing loss, hemi-neglect syndrome, patients with sensory conduction or global aphasia, musculoskeletal conditions like fracture, contracture and deformity, diagnosed neurological cases like Parkinsonism, dementia, etc., diagnosed systemic diseases like uncontrolled hypertension, etc. So the study variables, for independent variables, it was EMG biofeedback therapy and Bobath therapy. And for dependent variables, I took lower extremity motor function by lower extremity subscale of Fugl-Meyer assessment. So for Fugl-Meyer assessment, it basically checks the motor function in supine, then in sitting, and then in standing. So it has total score of 34 for lower extremity subscale. So this is the Consort 2010 flow diagram. Next slide. So the patients who were assessed for eligibility was 40. Out of that, 20 patients were excluded and 20 patients were randomized. So out of the 20 patients, 10 patients were allocated in group A and the other were allocated in group B. So group A received EMG biofeedback therapy and Bobath therapy for 16 sessions, that is 4 sessions per week for 4 weeks, along with the home exercise program. For group B, they received Bobath therapy only for 16 sessions, 4 weeks per session for 4 weeks, along with home exercise program. Then the data were analyzed. So the intervention for group B, it was Bobath therapy only, which includes some activities in lying, sitting and standing. All of the activities were meant to improve the motor function of lower extremity. Then for group A, it was EMG biofeedback therapy only and with Bobath therapy. So in group A, EMG biofeedback therapy was given to train ankle dorsiflexure for 15 minutes and Bobath therapy was done for 45 minutes, similar to group B. Next slide. Statistical analysis. So data was analyzed using statistical software for the social service, that is SPSS version 25 software. Descriptive statistics was used to summarize the patient demographic details. Chi-square test was used to check the homogeneity of male and female ratio. Paired sample t-test were done to within group comparison and independent sample t-test was done to between group comparison. The p-value was set as less than 0.05. Next slide. So for demographic details, for group A, group B, the mean age was around 50 in both of the cases, and for gender and affected side also, it was a non-significant group at baseline. Next slide. So for outcome measure analysis, Fugl-Meyer lower extremity at baseline for group A and group B, the p-value was 0.24, which was homogeneous, and when we were doing within group analysis, we can see that both for group A and group B, it significantly improves the motor function of the patient with a p-value of 0.00 and 0.00. Next slide. So when we did compare between group A and group B, we have seen that Fugl-Meyer extremity at day 0 and day 16, the p-values were 0.24 and 0.42. That means that the groups, between the group study, it was not a significant improvement when we are comparing between both the comparison. So now the discussion. So post-CFA hemiplegia rehabilitation aims to swiftly restore the maximal function capacity, emphasizing physical abilities to enhance independence and productivity. The Bobath therapy aims to regain normal movement of hemiplegic site through neuroplasticity, and biofeedback therapy on the other hand helps in motor training by gaining control over the selective motor unit activation. So Bashmaijan suggested that there were two possibilities for that. The first one was the development of new pathway or mobilization of old existing pathway. Right, so there was a study conducted by Gulsen and Dost et al. Who actually studied the effectiveness of EMG biofeedback therapy over the conventional intervention, and they found out that EMG significantly improved the clinical and functional parameters over the conventional rehabilitation program. In our study, it showed that improvements in motor function of lower extremity were significant in both the groups.
Your time is up.
Thank you.
I only have one question to you. The duration of the stroke, you have taken a very wide margin from 3 months to 3 years.
Yes.
Why was that so?
Sir, 3 months, actually there was a study which suggests the early chronic phase, and for 3 years also the late chronic phase. So I am basically taking the chronic stage of the stroke, and sir, in chronic stage there are studies that showed that improvement in the EMG biofeedback therapy and also Bobath therapy. So my target was to take the chronic people, because a lot of studies says that in chronic phase it is kind of impossible to improve a lot, but with my study I have also seen patients that in chronic phase, if we do Bobath therapy and EMG therapy, biofeedback therapy properly, there is a significant improvement in patient lower extremity function.
That's good. But don't you think that there would be a more significant improvement in the 3 months duration cases?
Sir, during 3 months, I don't think in some of the cases, I don't think patient will get to that stage that I am taking, right? Brandstrom stage 3 and 4. So patients need to go.
That's what I'm saying. Then you should have excluded the 3 months. Either go for chronic 3 years. Okay. Yes.
In addition to this question, I just want to ask you, because you have taken grade 4 or 3 and 4, right? Brimstone